Hello, everyone. Thank you so much for joining us. I'm Hartford Healthcare's Tina Verona, and I'm joined by Dr. David Chaletsky. He's a gastroenterologist here at Hartford Hospital for the Center for Advanced Gastrointestinal Procedures, which is quite impressive. Now, this four-suite center opened up just a few months ago, and it's quite impressive because you and the whole team of doctors and surgeons perform about 15,000 minimally invasive procedures every year. That's quite a lot. We're going to talk about some of those procedures, but that is quite a lot. That's impressive, 15,000 procedures a year.
We are quite busy, but we managed to take a team approach, and we perform a number of procedures, many of which are not performed anywhere else in the state.
Right. And this is really a training center as well. Not only are you performing these minimally invasive procedures, which we will get into, but you're sort of a national training destination for doctors to come here and train, and one of the most elite in the country, training in radiofrequency ablation, and we're going to talk more about that.
Correct. We have been performing radiofrequency ablation for about 10 years, and we have managed to develop a reputation around the country as a very busy center, as well as a high-quality center. In fact, we were involved in a large national study, and we were always in the top quartile in terms of quality of care, and we were recognized for that by becoming the Northeast Regional Training Center for that procedure.
So let's talk about radiofrequency ablation. It's a long word, and people probably hear that often, but what really is it?
So it's a very simple procedure. It's performed using an upper endoscope, which is a very simple procedure that's performed under sedation, and we put a little camera into the esophagus. And when people have a condition called Barrett's esophagus, which is a precancerous condition from acid reflux, we can easily remove those cells using heat energy applied to the inner lining of the esophagus. And it essentially eliminates the Barrett's tissue and eliminates the risk of cancer.
And so Barrett's esophagus, it's sort of like you were talking before, how it's the body's way of sort of protecting the esophagus, but it's protecting the body, it's protecting it, but then it's also harmful too.
Correct. There are a number of things that happen in the body. The body's a very smart thing, and in the esophagus, when acid continues to touch the esophagus, the acid is meant to digest food in the stomach. The lining of the esophagus is not meant to handle acid. So when that happens over years and years, the lining of the esophagus changes into cells that mimic the intestine, which is more likely to handle acid. Now, that's nice for the esophagus.
Right.
However, it's not good for cancer risk, and it can develop into cancer, and that's obviously not a good thing.
So if you do develop precancerous lesions, what's the next step? What does a patient do? What do you do?
So what would happen first is the patient would come to us and meet us in the office. Since we do take a team approach using what we call endoscopic eradication therapy, which is a number of procedures used to treat this problem, they'll sit down with us and we'll go over all of their previous results, and we'll likely perform another endoscopy to understand what to do next. And then we'll come up with a plan. We'll devise a plan together, and it's a two-way street. We discuss best options, and that may require meeting other colleagues in our group, and we find a way to remove that abnormal tissue. And it does require some procedures. Unlike surgery, this is a slow and steady process. So it may be a number of procedures, but the goal in the end, I tell my patients, it's like the turtle and the hare. They both get there at the end. We're the turtle, and we have our patients go through this system. And even by being in the system, in the so-called system, in our process, your risk will be diminished significantly because you're being monitored, you're being treated, and in some cases we do have to have our surgeons involved. They are part of our team, because some people do require surgery. But we're finding that we're identifying these precancers much sooner. So it's a much smaller risk and a smaller procedure to perform.
And it's really a multidisciplinary approach. When you have, a team of doctors like yourself, but then there's also surgeons for those patients that do require surgery. If it's beyond minimally invasive treatments, there are surgical procedures that are still performed.
Absolutely, and those procedures have come a long way in their own right, My thoracic surgery colleagues are doing amazing things, and they are absolutely part of our treatment plan. And some patients, we have them meet our surgeons either way, just so they understand all the different treatments. In the past, all we had was, maybe even a little more than 10 years ago, all we had was monitoring these acid reflux, precancerous changes, and surgery. We had nothing in between. Now we have a number of modalities in between that we can offer. Some will work for people, and some may still require surgery. But at least people will understand that there are lots of options now.
Cryoablation is another minimally invasive procedure that you do perform at the endoscopy center?
Correct. Cryoablation therapy and hybrid APC, these are other methods. Cryoablation is similar to people going to their dermatologist and freezing off a small spot on their skin. We're doing the exact same thing in the esophagus, and it's working quite well. We also have, we can even now treat small cancers in the esophagus through the upper endoscope. There are procedures where we can remove and resect small pieces of tissue without the need for surgery.
Wow, we are talking with Dr. David Chaletsky. He's a gastroenterologist here at the Center for Advanced GI Procedures here at Hartford Hospital. We encourage you to ask him a question about Barrett's esophagus, acid reflux, minimally invasive procedures. We're covering it all tonight. Let's talk about sort of going through the process, you know, because we mentioned a few minimally invasive procedures. There's a lot of information out there. A lot of people, you could easily get confused by what is out there. So sort of take us through the process. You know, if you're somebody with acid reflux, that you could be at high risk for developing precancerous lesions, or maybe you do, what do you do? What is a patient to do? What's the first thing or the next step?
Sure. And as a gastroenterologist, I'll often see patients who come from their primary care physicians, and they've had reflux symptoms for years. Now, I don't want people to think that everyone who has acid reflux is going to get cancer. That's not true. Esophageal cancer is not one of the most common cancers in this country. It is, by the way, one of the fastest growing cancers. And when someone does have precancerous changes in their esophagus, they often will come to me. We go over all the information. It's about information and communication, and that's what our process is about. So you'll meet someone on our team, and we'll go through all the different options. We'll talk about what types of problems you have. There are different types of precancerous changes, different types of Barrett's esophagus, anywhere from low grade to high grade types, and there are different treatment options based on that type of problem, and there are different treatments we have. So what I'll often do in that first visit is just help people understand what they have, and they've probably read a lot online and looked online, and try to help them understand what to do next. And then we come up with a plan. Our team is all about a game plan. We feel like people want to have an understanding of what they have, and they want to know what the next steps are and what to expect, not just the next procedure, but maybe a few steps down the road. So we map it all out, and I have people understand that when we do these ablative therapies, they're not a one-time thing. Like I said, it's more the turtle than the hare. So it's an average of 3 or 4 procedures, and I tell people right up front, these are procedures that are done at the hospital. They are endoscopy, but we are doing some ablating, removing tissue. You may wake up with some discomfort, but 1 in 5 patients have some discomfort after the procedure. It's extremely low risk. There's very little risk of complications. And in the end, the goal is to remove the abnormal cells, and we monitor in between as well to make sure that we're doing what we should. And if anywhere along the way there is maybe progress that we're not happy with, then we look for different modalities. And luckily at Hartford Hospital, we have a number of modalities to choose from.
Right, and what's nice too is that you did say that these procedures are maybe 2 or 3 visits, but what's nice is you go home the same day, and they're non-invasive.
Correct. These are same-day procedures. I tell my patients it's very similar to your upper endoscopy you may have already had to determine you had these precancerous changes or cancerous changes. The only difference is I'm doing something in there a little different. And yes, they don't have to stay overnight typically. Some of our procedures that are a little more involved may require an overnight stay, but typically it's a daytime procedure.
Let's talk about diet. Diet, of course, is a big influencer on acid reflux and causing acid reflux. What are some of the foods that are real culprits in producing acid reflux?
Right. So first of all, maintaining ideal body weight is very important. So food in general, it has been shown that those who are over their ideal body weight do have a higher risk of acid reflux and sequela or complications of acid reflux. Certain foods to avoid would be fatty foods, also certain fruits that are high in acidic content, citrus fruits, the typical things, tomatoes. I have a lot of people saying green peppers. There are a whole spicy foods, exactly. Alcohol consumption, significant alcohol consumption will unfortunately create more reflux. What it does is it weakens that little sphincter muscle, which is a little valve, a check valve down at the bottom of the esophagus that prevents the acid from coming up. All of these things, in fact, peppermint, those can weaken that little, temporarily weaken the esophagus. So these are items that you may want to consider avoiding and may help your symptoms.
Is it the acid in it that weakens it? What is it about the food that weakens that?
So the short answer is we don't really know.
Yeah.
However, we feel that there are some factors in these foods that actually involve that little sphincter, that valve. That valve is the key.
Right.
We still have yet, in 2018, around the world, don't have the perfect fix for that valve. That's why a lot of people have to maintain diet modification, stay on antacids, and that's important to do. But that valve is the key.
And it sounds like it's delicate. Is it? It sounds like it's very extremely delicate almost, because if you're eating these foods that could have an impact on that, it doesn't seem pretty strong.
So it is delicate, exactly. It's interesting. We think it may not necessarily be the fact that the muscle is weak. It's the neuromuscular pathways that connect back and forth to the brain that sometimes cause it to misbehave.
Now, if you have had acid reflux for years, are you at high risk for developing precancerous lesions or ultimately cancer if you haven't treated acid reflux and you've had it for years?
Yes, absolutely. So we have national guidelines that have suggested certain patients who are more at risk than others of developing these precancerous changes. One item on that list are people who have long-standing chronic reflux. Now, like I had mentioned before, 40% of the time, people have no symptoms. It's really hard to figure those folks out. So we're really dealing with the tip of the iceberg sometimes. People who have symptoms, those are the folks who are certainly at higher risk. Those individuals who have a significant family history of esophageal cancer, certain lifestyle factors, obesity, drinking alcohol significantly, cigarette smoking, those are individuals who most certainly, if that's something that someone out there has, a lot of those factors, should talk to their doctor and potentially get screened.
Yeah, sure. Esophageal cancer is relatively rare, would you say? Or are you seeing an uptick in cases at all, or is it still pretty rare?
Yeah, so that's the interesting part, is it's certainly not the most common cause of cancer in this country. It's not even the top 5 list. However, the incidence is rising faster than any cancer in this country. And some reasons we are not quite sure. And that's why we try to be very vigilant about screening. And in fact, our national guidelines about 2 years ago and a new one this year have come out with these guidelines that suggest certain people should actually be screened, just like you get a screening colonoscopy. I have lots of folks who come in for their screening colonoscopies, and we talk about other symptoms, and I ask them about heartburn, long-standing heartburn. And those are folks who also may need a screening upper endoscopy. The good thing is, if you get a screening upper endoscopy once and there's no changes there, then usually that's enough.
You're pretty good, yeah. So it's not something you would have to keep doing every year, like a colonoscopy or a mammogram to keep getting screened. And you talk about screenings, could that play a role too? Because you're doing more screenings, so you're finding more precancerous lesions or esophageal cancer.
So we think some of it is that. We are luckily picking up cancers. Unfortunately, we're finding more cancers, but we're finding them at an earlier stage. And that's why we have this whole group of modalities, not just monitoring and surgery. We have all these treatments in between that are treating all these small cancers successfully. Now, that's only part of the story. There are other factors that we're not quite sure why the incidence is rising. But if that's a lot of it, then that's fine, because we can pick those cancers up sooner.
Right. And in terms of once you're screened, in terms of monitoring, then what does the monitoring entail? Like, once you're in the system, you said, you're in the system, you're monitored.
Right. And that monitoring process goes on whether you require treatment or not. And that alone, even just the monitoring, reduces that risk. It depends on what type of precancerous changes are there, what level of this Barrett's esophagus we talked about. Depending on that determines how often one would need to be monitored and screened. Anywhere from every 3 months in certain cases to every 3 to 5 years, because there are some types of precancerous changes in the esophagus that are extremely low risk and don't require careful monitoring yearly or even every other year.
And then if you have precancerous lesions, or if you have cancer, what is the monitoring like after that?
Right. So that's something I tell my patients on day one, is even though we will remove the abnormal tissue, you still need to be monitored, you still need to be on medication. Again, that also is determined by what type of Barrett's they started with, but that can be anywhere from every year. I have some patients who've gone through the ablation process, had it all removed, and now are coming back every 3 to 5 years. And whenever they're getting their colonoscopy, let's say they come in and have their endoscopy.
Have that done too. Are they essentially still at high risk, considered to be at high risk, because they've had a previous history?
So there's not enough data out there to understand fully what patients' risks are after the ablations. However, I will tell you that there have been studies out there that suggest, for example, after 5 years out from one of these ablation type procedures, about 92% of patients are still disease-free.
Wow.
So yes, there's still probably elevated risk compared to the average population, but it's still quite low.
But in the fact that I think that they're being monitored is such a huge thing, because once you have it, like you said, you're being monitored. So.
Right, we see our patients for life at that point, and that's fine with us.
Absolutely. So we have a question from Desiree. She's 29, but she says at age 21, she was diagnosed with Barrett's esophagus. She's had 3 upper endoscopies. Would she qualify for any procedures like this? She says she takes 80 milligrams of Prilosec. Thanks for the question, Desiree.
Yeah, thanks, Desiree. Thanks for this very good question. So the short answer is maybe. But I'll give you a little more detail. So it's likely that you have what's called non-dysplastic Barrett's. And depending on the length of the Barrett's, in some cases a very short amount of that Barrett's, the non-dysplastic, is extremely low risk, probably about 0.2% chance per year, which is very low. So it may not require anything but monitoring. If it happens to be what's called a longer amount of Barrett's, a longer segment of the esophagus has the Barrett's, then that is considered one of those risk factors. And the fact that you are quite young at the onset is probably worth a discussion with someone who performs these ablative treatments, just to understand what it's all about and maybe just be monitored periodically, because during that monitoring process, if it ever does increase to the next level, we want to be ready and prepared to do what we need to do for you.
And does it matter where, in terms of the procedures that we have, and you have a plethora of procedures that you utilize, but does it matter where the esophagus, these precancerous lesions or cancer could be, if it's toward the bottom or the middle or at the top? Does that matter in terms of what procedure you use?
So that's the good news. We can employ any of these procedures for any of these areas in the esophagus, whether it's middle, top. Usually it happens at the bottom. There are certain types of Barrett's tissue that is a little more bumpy, we call nodular, and that does require certain procedures. In fact, a certain procedure that one of my colleagues performs here at the hospital, he's the only person in the entire state that performs it, and we're able to remove those little nodules, those little bumps, in order to remove that precancerous tissue.
Yeah, it's a big deal. Gloria asks, she says, I have acid reflux, GERD, been taking omeprazole for years. I try to wean myself off and the symptoms just keep coming back. Should I be worried about precancerous lesions? Thanks for writing in, Gloria.
Thanks, Gloria. So another excellent question. So the short answer to that one is symptoms don't always correlate with Barrett's. So I have patients who have terrible symptoms, similar to what sounds like you're having, despite being on lots of medication. and have no issues with Barrett's have a condition called non-erosive reflux, which doesn't lead to Barrett's. I have other people who have very minimal symptoms and they could have Barrett's. I think the important thing is if you've had these symptoms for a while and they are significant, if you have not had an upper endoscopy for screening, this would be the time. That one-time upper endoscopy will tell us what your risk actually is.
Yeah, I think screening is so important. I mean, whenever you talk about cancer, whatever type of cancer you're talking about, the screenings and the monitoring is so vital.
Absolutely.
You can't stress it enough.
I give my patients analogies. It's like scheduled maintenance for your car.
Right, right.
And you take your car in for oil changes all the time,
right.
and this is your own body. And getting that upper endoscopy, you know, some people ask me questions about what is an upper endoscopy like, and you know, is it what happens? It really is a very simple process. We do employ sedation, so you really don't feel or remember any of it. It takes about 10 or 15 minutes. It's performed in a very controlled setting. And the amount of information we achieve in that 10 or 15 minutes is immense. And whether we rule in or rule out a problem, it provides us significant information, gives you peace of mind, and allows us to treat something if it's there.
What types of information can you gather from that? Could you tell if someone is prone to developing precancerous lesions? I mean, how sophisticated is the information you're getting?
So we can determine if someone has evidence of acid reflux, and that alone puts you at risk.
Right.
It doesn't necessarily mean you have to come back for procedures and tests all the time, but at least allows us to understand what's going on there. It also can pick up small changes in the esophagus, that Barrett's esophagus. We utilize different types of modalities to even sample the esophagus now, whereas in the past we only had these small tools that could take little bites of tissue. We actually use a specialized brush now, which has a method of obtaining tissue in a much larger area. It looks like a little pipe cleaner. And we send it to a specialized lab, and they do genetic testing on the tissue to see if there are genetic markers to determine if someone's at elevated risk. And while some of this information is still in the development phase and research phase, someday, my hope, and I think it'll happen sometime soon, I'll be able to tell someone when they wake up after their results are back, whether or not, based on what their tissue looks like under the microscope, whether they have an elevated risk, no risk, minimal risk of developing Barrett's esophagus. And that'll help our plan much better.
Yeah, absolutely. And then for those who you know, have acid reflux, I'm sure you get this question all the time, are they, you know, going to be on anti-acid medications forever?
So my short answer is no. I think these specific medications out there we'll find something better in the near future. For the foreseeable future, the short answer is yes. Studies have shown that being on these antacid medications for people who have chronic GERD reflux, certainly people who have precancerous changes, Barrett's esophagus, they prevent cancer. So yes, but they've been around for a long time, they have minimal risk, and they work extremely well.
So for those folks out there watching us right now, who should be screened? Who should have an upper endoscopy?
So the typical person would be someone 50 years old and older, someone who has a bit overweight, has a high body mass index, someone who eats a high-fat diet, people who have a family history of esophageal cancer, people with that long segment of Barrett's that we talked about before, and those individuals who have a concern. They've had symptoms for a long time. Now, keep in mind, the symptom, it's not just heartburn.
Right, I was going to ask you.
Right, people have other symptoms, chronic cough. I see patients with throat clearing all the time. And you know, those patients also need to be monitored if it's a frequent thing. Now, again, back to what I said earlier, not everyone with acid reflux has these precancerous changes. But if someone comes to me and said, for the past 10 or 20 years, I can't stop clearing my throat, I can't, you know, I gag all the time, or, you know, I have chest pain or chronic cough, it may not be a lung problem, it may be reflux.
Right.
So
Because
And-
that's what you would think of initially. Like if you think of a chronic cough, you know, a lot of times you think lung cancer.
Yep,
Yeah.
exactly.
Yeah.
And I get referrals all the time
Yeah.
from my lung specialist colleagues and other people saying, we've done everything we've looked
Right.
at, this might be reflux.
Right.
And going back to some of the lifestyle modifications, you know, it's not just you know, the foods, we talked about the foods, but it's also things you can do.
Sure.
So raising the head of your bed, elevating the head of your bed. For example, 30 degrees, it doesn't have to be that much. But if you think about it, you eat food late at night. Eating food late at night is probably the worst
That's
thing
probably-
you can do
that's
for
a
your
no-no,
reflux. You eat food, you go to bed, you
On
lay
so
on the-
many levels.
Well, right, exactly. But you know, you're sitting up like this, you're
Yeah.
eating, gravity helps. When you
Yeah.
lay down, guess what? Gravity's not helping you
yeah.
anymore.
Yeah.
So you have to be mindful of that.
Dr. David Chaletsky, thank you so much. This was certainly an enlightening conversation, and we appreciate you stopping by tonight. Thank you.
My pleasure.
And
Thank
we
you.
thank you, of course, for asking your questions. If you would like to learn more about the Center for Advanced GI Procedures, Dr. David Chaletsky and his team, Regional Destination Training Center, and one of the top in the country for advanced GI procedures, we invite you to call 1-855-HHC here for more information. Thanks once again for joining us. I'm Hartford Healthcare's Tina Verona. We'll see you next time.